Hi, this is Mustafa Nadi, Assistant Professor at Faculty of Medicine, BAU. This is a lecture for fourth year CNS tumors. CNS tumors considered the second most common cancer in children and the sixth common cause of cancer death in adults. 1/4 of all tumors in adults are in the brain. This diagram illustrates the frequency of CNS tumor with age, and started from day 1 until 80s. And we can see the incidence of all CNS tumor increases with age. And another piece of information that this diagram provides us is the high-grade gliomas are the most common type of the tumor in comparison to the rest types of the tumor. In fact, we don't know what causes brain tumors, but some hereditary syndromes predispose patients to a certain type of brain tumors. But we have some correlation with gender. For example, gliomas are more in males, whereas meningiomas are more in females. Radiation is implicated as a causative factor in meningiomas, gliomas, and nerve sheath tumors. Primary CNS lymphoma is associated whenever there is immunodeficiency status in the body. So far, no convincing evidence linked CNS neoplasms with occupation, diet, and electromagnetic field. Of these hereditary syndromes that associate with CNS, the most important, and usually we focus on them, the NF1 and NF2, neurofibromatosis 1 and neurofibromatosis 2, followed by tuberous sclerosis and von Hippel-Lindau. These are 3 or 4 important syndromes that we focus, and frequently will get asked in neurosurgery, neurology, pediatric age group, pediatric rotations. So for neurofibromatosis 1, so the gene locus is at chromosome 17q11, and the gene is neurofibromatosis 1, and this syndrome or hereditary syndrome predisposes patient to neurofibromas, optic nerve gliomas, and meningiomas. Neurofibromatosis 2, the gene locus is located in chromosome 22q12, and the gene in F2, and that predisposes patient to schwannoma and meningioma. In fact, the hallmark of NF2 is bilateral acoustic schwannoma. Tuberous sclerosis, we have 2 types, tuberous sclerosis 1 and tuberous sclerosis 2, and they have 2 different genes. For 1, the gene locus on the chromosome 9q34, and type 2 is the gene located on chromosome 16p13. And both of them, they predispose patients to SIGA, subependymal giant cell astrocytoma. Von Hippel-Lindau syndrome, the gene locus is in chromosome 3p35, and the gene is von Hippel-Lindau gene, and the syndrome predisposes patients to hemangioblastomas. Glyphomani syndrome, the gene is locating on chromosome 17, q13, and the gene is p53, and this syndrome predisposes patient to glioma. For Gorlin syndrome, the gene locus in chromosome 9q31, and that predisposes patient to type of syndrome that previously called PNET, which is now not existed in the most recent CNS tumor classification 2021. how do they present? So people, they present with different kind of symptoms, and that depends on the location, size of the tumor, and type of the tumor. In general, neurological deficits approximately in the two-thirds or a little bit more than two-thirds of the patients. And most common uh, presentation of neurological deficit is motor weakness, which constitutes around, per se, almost shy of half of the patient, almost 45% of the patients. Headache itself as presentation, actually more than half of the patient represent with headache, and 1/4 of the patient they present with seizures. Also, for the cortical lesion, they may present with mental and personality changes depending on the location of the tumor. And the deficit could be focal or extensive, and sometimes the deficits could be due to increased intracranial pressure. So you can't localize it just because it increased intracranial pressure of the patient. So depends on the location. There's a little bit more explanation. So if for cerebral tumor, so that may lead to language disorder, like Broca aphasia or Wernicke's aphasia, motor for Broca and sensory for Wernicke. It depends on how this area are affected. Or may present with contralateral weakness or hemisensory loss, and may present with seizures and mental and personality changes. For cerebellar tumor, if the tumor in the hemisphere, that results in ipsilateral limb ataxia, dysmetria, intention tremor. If the tumor in the midline, vermis, that results in wide-based gait, truncal ataxia, dysdiadochokinesia. And the tumor could be in the brainstem, could be in the pituitary area, could be in the spinal cord, and we'll expand on them in the next slide. For the brainstem, so that result in cranial nerve deficits like diplopia or facial weakness or asymmetry. And then a lung tract feature like distal motor weakness and gait disturbances. And significant percentage of them, they present with hydrocephalus because of the obstruction of Sylvian aqueduct. And one characteristic of brainstem tumor is lung tract deficit in one side and cranial nerve deficits or weakness on the opposite sides. So feature of increased intracranial pressure, the patient may present with headache, a blurry vision, vomiting, changes in the behavior and sleepiness, confusion, and double vision. And for the sign, you can see the patient sometimes confused, changing the level of consciousness, and abducens palsy, and this is significant palsy, and may present with Cushing triad, and this is actually late presentation for increasing the care pressure, and sometimes considered as difficult to rescue the patient at this stage, as the patient present with high blood pressure, shallow breathing, and bradycardia, Cushing triad. So what causes increased intracranial pressure in patient with brain tumor? Could be tumor itself because of tumor size, or maybe cerebral edema, bleeding in the tumor, obstruction of CSF flow. Depends on the age of the patient. Adults, mostly they present with supratentorial tumors in 85%, and the rest of adults present with infratentorial tumors. For children, actually a little bit different. They present more with infratentorial tumor, like medulloblastomas, post-fossa ependymomas, and post ascistomas, like around 60%. And 40% they present with supratentorial tumor. And this is the tint, and this is the cerebellum, and this is the cerebrum. Again, this is the tentorium cerebelli. Just we need to expand on some expressions in the brain tumors. So we can say sometimes we have glial tumors and non-glial tumors. Glial tumors, like from the origin of the cell, like astrocytes, result in astrocytoma. Oligodendrocytes result in oligodendrogliomas. Non-glial cells in the brain, meningiomas, schwannomas, could be lymphomas, or could be metastases. This is another important group. So they come from outside the brain and they settle in the brain. Another expression, primary brain tumors, that means it's originate in the brain. Secondary tumors, that they come from outside or the mets. Benign, usually they are slowly growing and do not spread. Malignant, so they are rapidly growing tumors and invade nearby structure, and they may go outside the CNS, for example, medulloblastomas. In terms of surgical location in relation to the brain parenchyma, so either they are extraparenchymal or extramedullary tumor, for example, meningiomas or schwannomas, or they are from the brain material or substance itself. So considered intramedullary like gliomas, or inside the ventricles of the brain, for example, choroid papillomas. That leads us to classification of CNS, and this is just a quick introduction for classification of CNS tumors. So we have WHO classification, the first edition in 1979. We can see the second edition, third edition, fourth edition, and fourth edition was revised in 2016. And we have the most recent one is 2021 classification. So basically, the basis of the classification based on histological classifications, cell type, cell size, pleomorphism, and then with time start to be a little bit more complex when they start to add immunohistochemistry and then further molecular integration with time. And until now, in 2021, we have some tumors completely diagnosed based on molecular markers. So this is just a glimpse, very quick thing about some changes that happened from previous one, WHO classification 2016, the most recent one, 2021. So actually there are changes in the nomenclatures. The entities now transform to types, variant to subtypes, and no more expression of anaplastic, but still we will continue to hear anaplastic because the previous groups studies was based on the 2016. So still we have mix up of classification. And then now tumor grading, instead of using Roman digits, now they are using Arabic digits as they are more clear. So they use 1, 2, 3, 4 instead of the Roman number. And for molecular markers, some tumors are determined histologically with tumor markers. Some tumors are entirely defined by molecular markers. So here, just I mentioned some tumors are determined histologically, and they add molecular markers on them. And this is just an example of classification of CNS tumors 2020, almost least one. This is not to be memorized. And here I just add the link so you can visit the papers about the classification, just if you need more detailed idea. And just where I'll go section of this classification, for example, gliomas, glioneuronal tumors, neuronal tumors. And we can see we divide them into adult type diffuse gliomas and pediatric type diffuse low-grade gliomas. And in the adult type, you can see astrocytoma IDH mutant, oligoglioma IDH mutant, and it should be 1p and 1p19q chromosome co-deleted, and glioblastoma IDH wild type. This is just as classification. This is not to be memorized. And then you can go to the other side. You can see pediatric type diffuse high-grade gliomas, and then circumscribed astrocytic gliomas, and you can see subclassification with them. So now we're discussing the most common types of brain tumors. So gliomas, most common primary brain tumors, and it will be or constitute 50% of all symptomatic brain tumors, and incidence increases with age, as we show in the second slides. And radiation is the only clear risk factor for these kind of tumors, and they originate either from glial cells or from their stem cells. And they include astrocytoma, oligodendrogliomas, and ependymomas. For astrocytoma is the most common type of gliomas. And we have cerebral astrocytoma, which are more in adults. And this is just a repetition of the symptoms of the supratentorial tumor, like or cortical tumor, like behavioral changes, seizures, contralateral weakness, and language problem. And if they are in the cerebellum, which is more in the pediatric, they present, for example, polycystic astrocytomas. So they lead to the symptoms, depends on if it is in the hemisphere or in the vermis. And if they are in the brainstem, we explained how do they present in the brainstem, like cranial nerve deficits. An example of grade 1 polycystic astrocytoma is a grade 1, mainly in children and young adults. And focal astrocytoma may be associated with NF1. And this kind of a tumor is with excellent prognosis after total excision. And this is the MRI for a patient with post-fossa tumor. We can see the tumor is in the right cerebellar hemisphere, and you can see this tumor composed of two major components, one solid component and one cystic component, and this is T2 weighted image axial cuts. And all this white or bright color is the fluid, CSF, fluid around the tumor. It give us the same signal of the CSF and T2. And here this T1 with the contrast, and we can see the tumor is enhanced, the solid part of the tumor. And we can see also in this other patient with juvenile polycystic astrocytoma, the same is polycystic astrocytoma. We can see cerebellar tumor that result in hydrocephalus. And this is the cystic part, and this is the nodular part or solid part of the tumor. Diffuse or fibrillary astrocytomas is a grade 2 or low-grade tumor, and most common in cerebral hemispheres in young adults. They are infiltrative in nature, and they have the potential to transform to a malignant gliomas. And we can see here MRI, T1, and T2. And T2 is a hyper-intense signal, and hyper-intense signal in T1 weighted images. When we used high-grade gliomas in previous classification, 2016, we mean that grade 3 and grade 4. Grade 3, anaplastic astrocytoma, as I mentioned, in the most recent classification, it does not existed anymore, but still we continue to use them just because of the overlap period. And grade 4 is a glioblastoma multiforme. In most recent classification, it is a separate disease. And the peak incidence for high-grade tumor is middle to late adulthood, and they constitute more than half of the cases of the gliomas. A little bit more expansion on anaplastic astrocytoma. So based on histology, they showed increased pleomorphism, enlarged nuclei, and increased proliferative and mitotic activity. There should be no necrosis or endothelial proliferation that distinguishes them from GBM. The presence of either one or both is suggestive of worse biological behavior. And these are the MRI for a patient with anaplastic astrocytoma. We can see the flare. There is left posterior parietal or parietal hyperintense signal mass. And T1, we can see it is hypointense in comparison to the normal cortex on the right side. And after contrast, we can see patchy or mild enhancement with contrast. And this is coronal cut. You can see the same pattern when we compare it with the axial cut T1 with image with contrast. Glioblastoma multiforme is very aggressive tumor and can cross the midline. And when they cross midline through the corpus callosum, we call this pattern is butterfly pattern. And here, this also GBM, you can see ring enhancing tumor. And this part, the non-enhanced tumor, is the central necrosis inside the tumor, hypointense inside. And this is gross section of glioblastoma multiforme, aggressive tumor. And even this is black discoloration is because of bleeding. High-grade tumors appear as contrast-enhancing mass in the white matter and surrounded by edema. Ring enhancement for glioblastoma multiforme. Low-grade gliomas usually non-enhancing lesion, and they are diffusely infiltrating the brain tissue. Low-grade gliomas are best associated with T2 weighted images as hyper-intense signal. The prognosis in general for astrocytoma. For GBM, 1-year survival. Anaplastic astrocytoma, they survive up to 3 years. For low-grade glioma, actually they survive more than 5 years. And some of low-grade gliomas, they survive for decades as well. Usually they die because of transformation of a tumor to high grade. Another type of brain tumors is oligodendrogliomas. Apparently, quite obvious that the origin is from oligodendrocytes. And we know that oligodendrocytes, they produce white matter in the brain, and they constitute up to 7% of all intracranial gliomas. And there should be in their molecular study just to show 1p, 19q co-deletion or less of heterozygosity. And they, in CT scan, they appear with calcification in significant percentage of them. And there's redirection to the frontal lobe. Most often, they present in the 3rd or 4th decades of life. They are infiltrative. And we can see here how they appear in T2 weighted images, hyper intense signal. And they give us the pattern of fried egg. So the egg here is considered the nucleus, and you can see generous cytoplasm around the nucleus. And the prognosis for low-grade oligodendroglioma, they survive up to 15, 16 years. And for anaplastic oligodendroglioma, they survive for 5 years. Most patients died again because of negative transformation of the tumor. Ependymomas, they arise from ependymal cells, which are intraventricular cells. They are more in children, and they constitute around 10% of pediatric intracranial tumors. And 5% of adult tumors are ependymomas, most common in the 4th ventricle, and they present with feature of post-fossa tumor like ataxia, vertigo, features of increased ICP. And in the spine, they are more common in adult, phylum terminale, like myxopapillary ependymomas. And for intracranial ependymomas, they are more in children. This is the MRI for post-fossa ependymoma that occupies the 4th ventricle with hyper-intense signal and some heterogeneous pattern because of the CSF or fluid signal around the tumor. 10-year survival is approximately 50 to 70% of the cases, and good prognostic features when the patient presented early in life, young age, infratentorial in terms of location, and when they are possible to resect them totally, and the study shows they are low-grade tumors. Another important tumors is medulloblastoma, most common malignant brain tumors in child age group. And small cell polygonal tumor of the cerebellum is considered the origin of this kind of a tumor. Usually arise in the cerebellar vermis in the region of apex of the fourth ventricle, often present with signs and symptoms of hydrocephalus and increased neck pressure, and all medulloblastomas type are grade 4. It's a really malignant tumor. So overall account for 7% of all brain tumors. Approximately 20% of brain tumor in pediatric age group are medulloblastomas and constitute 40% of tumor of post fossa. And the peak incidence at age of 5 to 6 years. And in children, this is in children, and there's another peak in adult, which is around 25. So we have two peaks for this tumor at age 5, 6, that's in children, and if they're adult, the peak age is at age of 25. So this tumor is a little bit more in males more than females. So how do they present? And we mix up here with some feature of brain tumor in pediatric age group as well. So they may present with raised intracranial pressure because of the obstructive hydrocephalus. And symptoms of increased intracranial pressure can change with age. So for infant, because they have open suture, they present with just irritability, anorexia, failure to thrive, and big heads. In the younger age group, so for nonverbal patient, they present with behavioral changes, irritability, vomiting, and decreased social interaction. For older children and adults, so they present with early morning headache. They start to complain and express themselves about the headache or vision. So again, signs depend on the location of the tumor. If it is in the cerebellar vermis, they present with ataxia. And the tumor in the hemisphere, they present with dysmetrias, worsening in handwriting, difficulty in running, and slurred speech. If there is some brainstem invasion or compression, so they present with lower cranial nerve deficits. And for dissemination, if there is any leptomeningeal dissemination of medulloblastoma, they present with radiculopathy, and there is extracranial metastasis, for example, to the bone, they present with bone pain, and may go to lymph node outside the neural system. So these are images of medulloblastomas. So here we can see this is CT scan without contrast, and we see post fossa hyperdense lesion. Down here, we can see CT with contrast, just wide enhancement for this hyperdense lesion, while MRI without contrast, T1 weighted images, we can see a solid portion of the tumor that appear a little bit hyper intense, and there is a cystic portion. Here in T2 weighted image, we can see it is mildly hyperintense tumor, and this is the cystic portion of the tumor. And when you give it contrast, we can see just irregular patchy enhancement of the solid area of the tumor. Treatment, surgery, maximum safe resection, followed by radiotherapy and chemotherapy. That leads us to discuss another type of tumor that also may show itself up in the post fossa, but with different age group. which is the hemangioblastoma. It is a highly vascular, yet well-circumscribed tumor. The solid portion of it has solid part and cystic part of the tumor, and can be in the CNS, in the post fossa, in the retina, and in the spinal cord as well. The most common primary intraaxial tumor of post fossa in adult is hemangioblastoma. This is very important. So the age is different. It's an adult age group. And this tumor may occur sporadically or as part of von Hippel-Lindau syndrome. So important notice is it may be associated with polycythemia because this tumor produces erythropoietin. And it's not that common tumor, just constitute maximum around 2% of all the kind of tumors. Usually, if it is sporadic, they tend to occur in the fourth decade of life. If it is associated with von Hippel-Lindau syndrome, they may appear earlier in life. And how do they present? So similar to the presentation of, if it is, it depends on the location, if it is in the post fossa. So they present with feature of post fossa mass, like feature of increased intracranial pressure because of a tumor or hydrocephalus, and cerebellar signs depend on whether vermis or hemispheric. And we can see the images here. So this MRI T1 weighted image with contrast, and we can see there's left-sided hemispheric lesion composed of cystic part and solid part, and the solid part is enhanced with some cystic area inside the solid part as well. So this is adult and has polycythemia, so this is mostly hemangioblastoma. And the differential diagnosis, if there is no age mentioned for the patient, so we consider that cystic astrocytoma, just as the part of differential diagnosis. Meningiomas. This is important subject, and this is the second most common of primary brain tumors. In fact, it's the most common extraaxial brain tumors. They originate from arachnoid capsules and constitute around 20% of all intracranial tumors, and mostly asymptomatic. They are discovered incidentally, most diagnosed in the 6th or 7th decades of life. Female are more commonly affected by this kind of a tumor. And sometimes we have multiple meningioma in approximately 10% of the cases, and we have to look for associated syndrome like NF2, these conditions. 90% of meningiomas, they are locating inside the cranium, and 10% of them in the spinal canal. Spinal meningiomas, they are more common in female. All family meningiomas occur with NF2. It is very rare in children. So meningioma could be due to radiation, or patients receive radiotherapy for other lesions, or could be after head trauma that may happen years previously. And could be due to viral infection or hormonal problems, because this kind of a tumor, they showed progesterone receptors, and this is a theoretical explanation, but for sure it is related, strongly related to radiation and head trauma. For the receptor of this tumor, the meningiomas showed expression for progesterone in 80% of women and 40% of meningiomas in men. This kind of a tumor is highly vascular, encapsulated, and attached to the dura. So it's supplied by external carotid artery. Also, this tumor results in hyperostosis of adjacent bone proliferation. So a significant portion of the tumor could be asymptomatic, and just we see them incidentally because we image the patient, for example, for head injuries or other reasons. And the symptoms depends on the location, and they compress the underlying neurostructure. For example, within the motor strip, they may present with weakness. Within the sensory area, they present with sensory abnormality and may result in seizures as well. So it depends on the location of the tumor, whether in the cerebral convexity, whether in the falx cerebri, whether in the skull base. CT scan, so you have to see a mass that is iso or slightly hyperdense, very closely related to the dura or dural based, and result to some sort into hyperostosis of the nearby bone. And sometimes associated with edema around the tumor. And if you give the tumor contrast, you can see it's homogeneously enhanced. MRI, a little bit different. It could be iso-intense or hypo-intense in T1 and T2. And it shows dural tail with MRI, and sometimes we can see it in the CT scan, and homogeneously enhanced tumor. This is just a further explanation about the surgical intracranial melanomas. They could be related to the tentorial or parasagittal or the sphenoid wing. And the growth rate, usually they grow approximately 1 centimeter per year. And the double time is variable from 1 year to 14 years. So how we treat these cases or tumors or melanomas? So we could observe them just by follow-up CT MRI. If they are stable, just we keep watching them. And if they start to produce symptoms or increase in the size, so they need surgery. And the idea is to do complete surgical resection. So it's a curable disease. And if there is any residual or recurrence, just go back again and resect the tumor, re-resection of the tumor. Another type of modality or modality of the treatment in addition to surgery is radiation therapy for residual tumors after surgery, and it's difficult to get back for any reason, or recurrent tumor, or if the tumor from the origin is atypical or malignant meningiomas. Pituitary gland tumors, they are a little bit specific because of their location and their production of hormones. It is third most common primary brain tumors, often asymptomatic, and most common in adults in the third or fourth decade of life. And they happen in 10% in children and adolescents. Usually it may be related to MEN1. So if the tumor is more than 1 centimeter in size, it's considered macroadenoma. If it is small, less than 1 centimeter, it's microadenoma. So the brain tumor with the micro or macro, they present with maybe with excess hormone secretion or hyperfunction, whether it's a growth hormone, gonadotropin, thyroid, prolactin, adrenal hormone. In addition to the production, so for macroadenoma, they do compress nearby structure like pituitary gland, nearby glands, and or neurostructure that result in hyperfunction or compression on optic apparatus. For the tumor also can be secretory or non-secretory, as we mentioned. So if secreting prolactin, that we call this tumor is prolactinoma, which is most common, intracellular endocrine tumor. And secreted whether it's micro or macroadenomas. A growth hormone problem, if there is increase in the growth hormone in the kids or before the closure of epiphysis, that result in gigantism. And if happens in the adult after closure of epiphysis, that result in acromegaly. ACTH secretion result into Cushing's syndrome. And we have 10% of cases that are mixed secretory tumor, more than one type of secretions. And in general, they are benign. Just very few cases, they may show malignancies. So manifestation locally, they may compress neural and vascular structure, result into headaches, visual hypofunction, and if there is any compression in the optic apparatus, it result in visual loss or visual field defect. So in pregnancy, they may enlarge and they may present with hemorrhage within the tumor, and we call that pituitary apoplexy. If the compression of the chiasm that result in bitemporal hemianopsia, if the compression is on the optic nerve, that may result into ipsilateral blindness, and if there's compression on the optic tract behind the chiasm, that results into contralateral heminomus hemianopsia. And this is the optic pathway tract. This is the retina on the right side. Oh, it's a, yeah, and the optic nerve, optic chiasm, optic tract, and this is lateral geniculate body, and after that goes optic radiation to the Mears loop in the temporal area, and then they go to the parietal, and then they end up in the occipital cortex. Any compression at each site will give you a different visual field defect. And this is a thorough explanation. For example, if the compression at the optic nerve result in blindness in one side, and if the compression at the optic chiasm, that result in bitemporal hemianopsia. And if the compression in the optic tract result into contralateral heminomus hemianopsia, and so on. This is normal vision. You can see completely in both eyes. This is, we can see in the both temporal areas. You will call that bitemporal hemianopsia. This compression in one optic nerve. So there's ipsilateral blindness here. Now you can see the lesion on one side, which is here. So contralateral compression on which optic tract? Optic tract, the contralateral side. If the tumor in the supracellular region or hypothalamus, this may result into feature of decreased cranial pressure because of the third ventricle, either compression or obstruction. Example of these supracellular tumors is a craniopharyngioma, whether in children or adults, and we have bimodal presentation. Craniopharyngioma can result in headaches, vomiting, and papilledema. And this is the MRI for patient presented with supracellular region that extended superiorly and posteriorly, invading third ventricle and exercising compression in the optic tract and optic chiasm, and even pituitary stalk and pituitary glands. We said 5% of pituitary tumor, they present with bleeding or infarction, followed by bleeding in the sella or pituitary gland, and we call this pituitary apoplexy. It is an emergency, and usually patient present with headache, nausea, vomiting. It depends on the size of a bleeding inside the adenoma, and this may result into visual loss and changes in the level of consciousness. And at that time, we need to do emergency surgery to decompress the optic apparatus and to replace the hormone deficiency. And we can diagnose them with CT scan and MRI. So diagnosis of pituitary lesions, the best thing is with the MRI to evaluate the pathology, size, signal of the tumor. And the treatment, surgery, hormone replacement, and radiation therapy. Lymphomas in the CNS could be primary, secondary. Mostly they are primary, and you can suspect them when you have homogeneous enhancing lesion around the ventricular system, and they may be associated with uveitis, and most of them, they are B-cell lymphoma. And as mentioned previously, they are associated with cases of decreased immunity of the body, like cases of transplant or SCID syndrome, and in cases of AIDS. And this kind of a tumor is associated with Epstein-Barr virus in almost all cases. And we can see here MRI, T1 weighted image with contrast, homogeneously enhanced lesion around the ventricular system, more than one, and in the pars fossa as well. So this is mostly CNS lymphoma. And actually, the differential diagnosis of this kind of a tumor could be MITS. So we discuss MITS after this. So when the MITS comes from outside the brain, and this comprise is almost more than half of the brain tumors in the clinical series, and approximately 1/4 of all patients with cancer, they develop brain mets. Most common primary site or origin of the mets is lung cancer, followed by breast and melanoma. Interestingly, 1/4 of the cases, we can find the primary, whatever we do for the patient to identify the source of the tumor. And CT scan, you can see here, there is a hemispheric, right-sided cerebellar ring enhancing lesion. And we can see here, different patient, cerebellar ring enhancing lesion, as well supratentorial with enhancing the area around hypointense area. And that goes into differential diagnosis of ring enhancing lesion. So what's the differential diagnosis? This could be MITS, could be GBM, and could be abscess, so as a differential diagnosis. But here we're discussing brain MITS. For the spinal cord tumors, broadly, we divide them into extradural tumors, intradural extramedullary tumors, and intradural intramedullary tumors inside the substance of the spinal cord. Example of extradural tumors, metastasis, or primary brain tumors, osteoma, or osteoblastoma, aneurysmal bone cyst, and sarcomas. Could be even lymphomas and other type of tumors like Ewing sarcomas. For intradural extramedullary lesions, could be meningiomas, neurofibromas, ependymomas, like myxopapillary ependymomas. And for intramedullary intradural lesions, could be ependymomas, astrocytomas, and oligodendrogliomas. This is just a little bit expansion on the list of extradural tumors. And in general, all brain tumors, can be treated with either observation or surgery or brachytherapy or radiation, and in malignancy, we need chemotherapy. And we discussed some of the questions here, just to consolidate what we discussed previously. So this is, these are images with and without contrast. And we describe the pattern of enhancement. So we need to be able to localize the abnormality. We can see here T1 weighted image with hypointense lesion in the right frontal area. And we can see some sort of hypointensity that represents what? Represents edema around the tumor. And when we give the contrast in the T1 contrasted images, we can see homogeneously enhanced tumor with a dural tail. And once you hear dural tail, you have a dural-based tumor. So we have to connect that to meningioma. And here, the same hyperdense lesion without contrast in the middle of the frontal or anterior fossa. And it is highly homogeneously enhanced lesion. and this is olfactory groove meningioma. But this one is dural base convexity meningiomas. So what's the most probable diagnosis is just simply meningioma. So, and then please describe the pattern of enhancement for the following patient images. What we can see the abnormality on the left side, and it's cortical, subcortical, and the type of the tumor is heterogeneous, solid part and cystic part with good surrounding edema that compresses the ventricular system and with mild shift on the midline, as we can see. And here we can see this tumor NT2 as hyperintense signal. Sorry, this is, yeah. And we can see the surrounding edema and the compression on the ventricular system. And with contrast, you can see a ring enhancing lesion with surrounding edema. And this is probable diagnosis is GBM. Here, so we have two different patient images. So one on the MRI of we can see a lesion, abnormality T2, weighted images, hyperintense signal in the left frontal area, hypointense in T1, and with contrast, we can see ring enhancement. So we can say, oh, this is GBM. That could be correct. And here we can see patients with left temporal hyperintensity with good surrounding edema. And you can see the pattern like patchy enhancement, not exactly as ring enhancement or ring enhancing lesion. So that could be as well, could be GBM, could be metastasis with tumor. And if there's history of infection, so that could be abscess as well. So describe the pattern of enhancement for this patient presenting with seizures. So we can see abnormality in the temporal lobe that consists of solid and cystic component of the tumor, and we can see mild enhancement. And that could represent anaplastic astrocytoma. So this describes the enhancement pattern of this patient images who present with seizures. So this patient, so you can see T1 hypointense lesion in the right frontal area and hyperintense signal in T2 weighted images, and with contrast is almost didn't enhance. This kind of low-grade tumor could be low-grade gliomas, could be low-grade oligodendrogliomas. And this scenario is a little bit different. So an 11-year-old patient who presented with headache, vomiting for 10 days duration. So we can see MRI, axial cuts, T2 weighted images, and you can see in the post fossa, left hemisphere, there is a lesion, mostly cystic, right? And this is the fourth ventricle. And T1 weighted images, you can see the signal of this fluid in T2 hyperintense signal here, T1 hypointense signal. And with contrast, you can see the solid part of the tumor, which is enhanced. And for 11-year-old, so that could be pilocytic astrocytoma. Another scenario for a post-fossa tumor that presented with the hemispheric part of the cerebellum and with cystic and solid component, which is enhanced nodule. But what's the difference? So now it's adult. So 40-year-old patient and presented with headache, vomiting for 10 days, same thing the previous one, but his hemoglobin is 17. That's polycythemia. And we mentioned when you see there's a tumor that presented in post fossa and has cystic and solid component, and solid component is enhanced in adults with polycythemia because of erythropoietin. This is hemangioblastoma. And let's read this scenario. This a 3.5-year-old male patient presented with anesthetic gait and presented with occasional vomiting for the last 3 weeks. He became more irritable and became thinner over the same period. Eye examination showed papilledema, which reflects increased intracranial pressure. How does the ventricular system look like? This is the first question. You can see there's the answer, increase in the size of the ventricular system. What is the lesion in the pons fossa? So we determined the lesion in the pons fossa. The question is more specific, in the cerebellum or in the ventricle. Apparently, it is filling the ventricles because we can see there is a CSF signal around this tumor, so inside the ventricle. What is the pattern of enhancement? Actually, it's a non-homogeneous enhancement of this tumor. His head CT scan showed some calcification, not shown. That goes mostly with ependymoma more than medulloblastoma. So what's the most probable diagnosis in 3.5-year-old male patient, right, is ependymoma. And just I'm leaving this clinical feature of neurofibromatosis to expand on them, as it is a very important syndrome, and you may see this syndrome and will be asked about it if you go to pediatric residency, neurology, neurosurgery. So yeah, it's very important. So they may present with low-grade tumor, optic nerve gliomas or high-grade gliomas, and they have skin feature like cafe au lait spots and freckles, and depends in the pediatric presentation from adult presentation. I would not like to make it more complex. And most importantly, they present with peripheral nerve tumors, plexiform neurofibroma, and predispose patient to malignant peripheral nerve sheath tumors. And in the eye, we can see some of the signs are called flesh nodules. And we have also other symptoms in the bone, in the other part of the body, just to make it simple as it is. It's in the image. And thank you very much.